pleasure of introducing a woman who doesn't require much introduction to this group, but Tina Palmieri, who is one of our senior distinguished burn surgeons who is really in charge of the burn unit here at UC Davis. As you know, the group takes care of burn patients, pediatric burn patients at Shriners and adult burn patients here. And she has with her a special guest, Dr. Jamie Peyton from the vet school. So I will turn it over to the two of you to update us on these important issues. Thank you.
All right, so it's my pleasure to talk today about something that has affected everybody who was not here last year in California. A couple people. Well, you missed the wildfires. You're about the only ones, but you're going to hear about it today, and I'd be ready because we've already had 3 wildfires in Yolo County in the last couple weeks. So wildfires are here to stay. And like any talk, we've got some disclosures. I've done some work, but I have no financial disclosures, but I'm a closet disaster magnet. So I've spent my whole career dealing with disasters, and hence I just embrace them because they're going to find me anyway. So I've helped create some of the guidelines for disaster management, and my disaster framework actually started when I served in the Air Force. And my triage paradigm is from the military. So I've brought that into my civilian work. And I've had a few experiences triaging patients, including the US and Mexico. And the only thing harder than triaging patients in the United States is triaging 150 toddlers with the Mexican government. Okay, so that was probably the most logistically difficult. Today we're going to talk about burn disasters, the landscape, and why, as surgeons, you need to know about it. Remember, who do they call when things get tough? They're going to call you if you're a future surgeon. So you need to be ready for this one. Talk about what we've prepared, some epidemiology, and then with Dr. Peyton, we're going to help broaden your perspective because wildfires aren't just about people. They're about the environment. They're about our families, and animals are part of the fabric of the family. And then some lessons learned. So are there more burns, or are we just imagining this? Well, someone actually looked, and between 1990 and 2000, the proportionate size of the dot is how many burn disasters there were. So, you know, you kind of expect it in Africa and China, and yeah, we have a little in the US. And recently, again, proportionate. Look at how these bubbles have expanded. Now, this does not include the wildfires we've had in the last 5 years. The US blue dot would be much bigger, and so would Canada's, because Canada has had a ton of really bad wildfires in the past year. So are we ready? We'll see. Yes and no. What steps have we taken? We have done some things. We've got these great burn center referral guidelines. Every lawyer in the United States knows them, and hence every ER doctor in the United States knows them. So everybody knows when to dial the phone. We've developed courses to teach burn care acutely. And I encourage anyone who's interested or who's going to be in a rural setting to take a course like this. We've actually even written national guidelines for how to take care of burn patients in this time of disaster. Do you know how many people in here have read these guidelines? Right. The burn community has. See, Dr. Romanowski has. Dr. Sen didn't even read them. So the burn community is aware of the guidelines, but not everywhere. We even have regional disaster teams. Now, these are the nationally designated burn disaster areas. And you're like, wait a minute, this doesn't match any regional thing. Look, at the West is like half the United States. You'll see why in a minute. We have also developed a triage disaster table based on the data that we've collected about burn survivability. And we actually wrote this here at UC Davis. This is ours that's been incorporated into national and many regional guidelines. So this is developed on objective data so that a first responder can say, oh, you're expectant, and do it from data rather than from, you don't look like you're going to survive. Okay. But there's some problems. There's a fundamental lack of training. Burns are not a required rotation for surgery. You have to know about it, but you're not required to rotate on it. There's an overall lack of experience and knowledge, and some of it is because burn incidence is going down, which is a good thing. Okay, I'm not arguing to go out there and burn anybody. Okay, we've lost wound care knowledge. What's the most common thing we do with the wound here at UC Davis? Put a vac on it. Okay, that's really nice. It works. Okay, but what do you do if you don't have one? How do you take care of the wound? How do you know the signs of a changing wound? And there's a decreased number of burn centers. The other thing is that because the lawyers have taught everybody how to dial your local burn center, there's more transport rapidly to burn centers, so local skills and local supplies at emergency rooms have dissipated tremendously because burns are high resource intensive. But the scariest part about this is that the average error in estimating burn size is 20% in both directions. So when we get a call about a burn that's 40%, it's somewhere between 10 and 60, or 20 and 60. That is makes it very difficult with all these diagrams. The other thing is that there's not a whole lot of burn centers. There's a total of 1,800 burn beds in the United States from 123 centers. Burns need lots of resources. Whenever the hospital goes through its resource utilization thing, we're like right at the top every time. So I just kind of crawl into those administrative meetings knowing that I'm going to be right at the top of that food chain. There's a limited number of trained burn surgeons. And more importantly, there's a limited number of dedicated trained nurses, therapists, and nutritionists. They're very specialized. That's actually the rate limiting factor in most disasters. Medication availability is a problem. The average burn patient is on 40 different medications, and that's from our own experience here. It's resource intense, but it's people, it's things, but most importantly, it's the knowledge of how to use those things that makes the difference in a disaster. And the pressure to cut costs has led to a loss of supplies. Every hospital has slimmed it down. There's not extra beds lying around. There's not lots of extra dressings lying around. There's not a lot of extra people. So although cost containment is very good, it makes it problematic in terms of a disaster. This diagram explains why the specific regions are developed for burns. You notice that if you're in the West, if you're in Idaho or a couple of these other states, there is not a single burn center in your state. Think about that. If you are a practicing surgeon in one of those states, guess what you're going to be doing? You're going to be seeing lots of the burns because that's where they come. In the Western Burn Center, we've actually developed a disaster network. There's a total of 24 centers, and you can see California has the greatest number. The red dots are verified centers by the American College of Surgeons and the American Burn Association. The black dots are people who put up a sign and said they're a burn center. Have never been verified. There's a lot of them, actually. Total burn beds in the entire western United States is 390. And the average availability is about 127. You can surge to 219. And surge capability is 1.5 times your normal capability. And I can tell you for the last 5 years, our burn service has been running on surge capacity. So I'm toying whether or not to just make us a bigger unit and so we can increase our surge even more. There have been 22 bed counts since 2004. In California, we're big. We have cities, but yet we have lots of urban areas. So it creates a lot of challenges. Let's switch to the campfire, which is why you're really here. It's number 13 since the year of all the fires since 1800. And if all you look at are fires post 1900, we're in the top 10 on this fire. It's the biggest fire that occurred in California. At one time, up to 1,200 people were missing. The phone lines were going off the hook. There are thousands of displaced and innumerable animals were injured. There are no major roads. There was one road in and one road out of this area. So transportation of patients was very delayed. It was hard to find them, even harder to get them out. And it was 90 miles to the nearest burn center. So why were we it? We were the only burn center that was contacted to all the triage. Because, as you can see from this, we are the closest. UC Davis, 90 miles. The next closest is both in Burn Center in San Francisco, and they don't have a helipad. So they would have to go by ground for everything. So we were the primary triage area for this. Now, we've been here before, because anyone remember the Napa fires in San Jose? We kind of got it then too. This was the Northern California wild storm. And at the fire scene, 22 were killed. We actually got 10 patients and had 2 deaths. These were very devastating burns. And 3 hospitals actually got evacuated in the middle of it. Right in the middle of a wildfire, suddenly your triage hospitals burn and infuse the entire content of 3 hospitals into the medical system. So this is triage on top of triage, which nobody has ever actually modeled yet. And it was 1.2 billion. Okay, so what about the campfire? Originally, everybody was triaged as Advanced Health and Feather River, and then that hospital caught fire. And guess what? They were sending patients out immediately. UC Davis, we were the primary receiving burn center. We got a lot of patients with no warning. And you couldn't really predict, because as the winds changed, people would be at risk for injury, because most of the people in Paradise were there to fight for their homes, so they didn't leave. They stayed to fight. And we activated the Western Triage Network. But at the same time this was happening, it's not just Northern California that catches fire. There was the Woolsey and the Hills fire, and I call them the celebrity fires. Okay, this was, like Miley Cyrus's house burned down and stuff. It burned a lot, but look at the evacuation. They could evacuate 295,000 people. You think you're going to get 295,000 people out of Paradise with 1 road in? No, it wasn't going to happen. Now, the Western Burn Consortium, when I started getting patients in, when we started getting them in at UC Davis, we activated the Burn Consortium and found out how many beds were available in the area. So in Northern California, there were 4 burn beds immediately available. At the time this started, our burn unit was full. But as every person who's rotated on the burn service knows, we create things. So we created beds to get people in. In all of California, there were 53 beds. So you can see there's not a whole lot of bed capacity built into California. So what happened? We ended up getting 10 here at UC Davis. 1 went to Botham, 1 to Santa Clara, and 1 person was so sick of Northern California, they drove all the way to San Diego before they stopped. And that's where they ended up, was in the San Diego Burn Center. 2 firefighters were actually injured in the fire, and the mean age, this was an older person's fire. If you take the firefighters out of the mean age, the average age was over 65. So this was an older person's fire. And they stayed for a long time. In fact, a husband and wife team stayed in for almost 5 months. So burn disasters come and they stay for a long time, 1 day per % burn. Lots of outpatients were seen, and if the fire wasn't bad enough, norovirus broke out in the shelters. So all those people in the Walmart parking lot who weren't in the shelters, they looked brilliant because they didn't get the norovirus. But the norovirus actually broke out in the other shelters. The human injuries are summarized here, as well as the evacuated, and lots of destruction. But this creates the next question, and Dr. Peyton's going to address this for us. What about the animals?
All right, I have some cute pictures for you guys. So these are actually, when we ask the question, what about the animals? These are 2 of the animals that presented to me when I was up working in Chico during the fire, during the campfire. And, I always start with these pictures because they just really exemplify sort of what we're seeing. This is a population that has often been forgotten with some of these disasters. But like the cat that presents covered in soot and they're scared, these are all brought in by the firefighters. So it's very important that we start considering them. Of course, I'm a bit biased as a veterinarian, but I think to myself, well, why is it so important to include animals in our disaster planning? And when we look at the impact of wildfires, especially here in California, well, the first thing being, of course, animal welfare. Animals, we're responsible, right? They're living beings. We're responsible for them. Whether they're companion or wildlife, they feel pain just like we do. They have the same physiology. They don't express it the same, but they still have that. And so we think a lot about dogs and cats and sort of those companion animals, but there's a lot of other ones. These are all from actually the campfire except for the fish. He was from a different fire. But all of these animals presented, so we're seeing not only our companion, but we're seeing horses, we're seeing llamas, we're seeing this guy over here, the tortoise. I have to get my little, whoa, This is crazy. Spotlight on Momo there. He was actually burned. He's a large tortoise, as well as our wildlife, and tons of poultry. You would not imagine how many burned chickens and ducks we had. So besides looking at that aspect of animal welfare, the other thing we need to think about is that human-animal bond. And this is huge because, again, we're looking at these family units. And I'll tell you, one of the most profound things to me, when I went up there, I actually went up to Chico and was working up there that whole time after the fire started for several weeks. And I'll tell you, people, these families would lose everything. And I'd say, I'm so sorry you lost everything. And they look at me and say, no, I didn't. I have my dog, or I have my cat. And these animals are part of the family. They also are part of the story of their survival and rebuilding. And so that's why it's important that we consider them. The other thing being, what people don't think about is when we look at our first responders, it actually is a big issue. When Katrina happened, well, it's not a wildfire, in 2006, they did a survey and found that 44% of the people who did not evacuate did that because they couldn't get their animal out. And so this is a huge thing because there are no plans really in place to evacuate animals. And there are no shelters that actually allow them. So the Red Cross does not allow animals in this. And that's a big problem because people, especially during the campfire, were living in their cars, were finding just random places to stay with their animals because they couldn't come into the shelter. And I have to say, where there were animals, there was no norovirus. Coincidence? I think not. No. But I have this picture of the chicken on here because one of the, again, things that really impacted me and made me remind this issue is there was a gentleman living in the Walmart parking lot, and I went to visit him, and he was living in a tent. He had lost his home, he lost all his belongings, and he was living with his 2 chickens. And he refused to go to the shelter, he refused to go anywhere because he didn't want to leave his chickens. So it was all he had. Unfortunately, the chickens had severe injuries, and we had to euthanize them. And seeing that was just devastating, and again, remind us why it's so important that we consider these animals. Now that we look at, well, 63% of the California households, and this was done several years ago, so I think this is even bigger number now, have pets. So we're looking at 10 million cats, 9 million dogs, 1 million horses. This is a much bigger issue than we had thought. And then that doesn't even account for all the agriculture. We have a lot of cows and horses. All of these need some place to go and need to be evacuated and then cared for. And then something that I'm passionate about as well is the wildlife. And everyone, again, forgets a little bit about that wildlife component, but we are responsible. They share our environment. We do need to help them. Just as a side note, this particular picture is actually one that was on Facebook that actually showed the difference between what those animals looked like before and after they were found. And it was very hard for owners to identify their pets. This one actually had a microchip, so it did get found. So beyond welfare and looking at the human-animal bond, we also have that component of numbers. So within the campfire, we saw over 2,700 animals in the shelters. So we had to find room for all those animals that presented, and a lot of them were brought in by firefighters. Not only that, but we had over 400 animals with the Medical Reserve Corps, our veterinary component, that was getting burn treatment. And that involved about 30 different veterinary hospitals. Now, these aren't coordinated. These were hospitals that stepped up to take some of the animals within the area. And then myself, I went up and worked at a referral hospital that has specialties, internal medicine, surgery, critical care, and we saw over 550 animals. And these are not just animals that presented and they're uninjured, they all had significant burn injuries. So it was really quite a lot. And then at Davis, we saw a variety of different animals, goats, pigs, horse, lots of poultry. It was kind of crazy. And then we have to think about all the animals that we actually didn't see and didn't account for that were still left. So looking at that, where do we go? What steps have we taken for the animals, considering them? At the federal level, we actually saw that in 2006, they passed the PETS Act. And that basically allows FEMA to reimburse us, so at both the state and local level. So you get money for helping to care and shelter some of these animals, but it doesn't organize anything. It just gives funds after the fact. So we still don't have anything that really helps organize when a disaster occurs. And those funds only apply to companion animals, meaning dogs and cats. It doesn't include rabbits, it doesn't include your livestock, any wildlife or zoo animals. So they get no help. But in California, we've actually said, well, we're kind of the state for disasters, unfortunately. And so they came up in about 2001 with this thing called California Animal Response Emergency System, or the CARE system, and said, well, we're going to actually give that to the California Department of Food and Agriculture that knows so much about disaster medicine. No, not really. So they actually said that, gave them money, but we really didn't establish any sort of organization. And in fact, on the website, it says those documents were never processed. So in 2006, they made it part of California Office of Emergency Services, but there's still nothing really in place. We don't have people organized. So it sounds great in theory, but actually in function, which we found out during the campfire, it doesn't exist. So there are other groups, our California Veterinary Medical Reserve Corps, which is part of our CVMA, our California Veterinary Medical Association, and they were kind of a big part in going on site, setting up the shelters, and then having help from local organizations, such as our University of California Davis Veterinary Emergency Response Team. That's made up of some faculty members and a few students that go out and volunteer and help at these shelters as well. And then there's a lot of other community groups. So you're getting the gist. There's like all these people that want to help animals, but we really have not had much organization. So in the campfire, we saw that CalMERC, or our Veterinary Medical Reserve Corps, was pretty much one of the main driving units and helping with that. They set up those 9 animal shelters. They had 313 volunteers, and then recruited these 30 voluntary hospitals. Now these are just all clinics from that area. They are not designated to treat burns. They are anyone who would help. And then, of course, our veterinary emergency response team at the school went out and helped at the fairgrounds, helped move animals to UCD for ongoing care, helped with a lot of the poultry. And really, actually, one of the most important things is set something up that had never been looked at before, which is called a passport program. Meaning, we had over 2,700 animals. Well, where do they go? Their owners don't have a home, or they can't find them. And it's overwhelming to the shelters, and we still have to track these animals. So they developed a program where they could track them. Thank goodness for students and their technical savvy. So for the animal side, what are our challenges? Well, as you've heard, in the field, and especially with the campfire, because it was such a big fire, and we had so many animals, we found that there was really little organization, not much out there. And we had no guidelines. There are still no guidelines for when and how to refer a patient that needs more extensive burn care. We're working on that, though. The other big thing to think about for the animals is, because of that lack of organization, because we haven't really considered them, there is no disaster sort of communication, calling hospitals, asking for beds. It's more of just a general call. And there's no organized transport for these animals as well. So then we look at, well, these veterinary clinics are getting a lot of the patients that have burn injuries, but we really have no recommendations of how they do it, for how they take them in, how they accommodate that. There's no disaster planning for these small clinics. And even more than that, this is something that I'm very passionate about, is there really is minimal education right now for burn care for animals. And, you know, we did a survey not too long ago, and most of the veterinarians out there really have not very much knowledge about how to treat these injuries. And that's important, and also who to call, because there is no such thing as a burn specialty. We don't have a fellowship. We have criticalists like myself and surgeons, but nothing beyond that, or someone to call. And I'm changing that too. The other thing is that we have very little in the literature. So when you're not sure of something, you look back into the literature. How do we treat that? Well, we don't have that in veterinary medicine, but we're hoping to change that. So just to finish off, to give you a little idea of what we were dealing with, the animals, like people, we're seeing smoke inhalations presenting, like the dog in the oxygen cage. We have set cages that get inflow of oxygen, and then lots of burn paws. Now remember, the specialized tissue, the paw pads, will never come back. So we're treating them and hoping that they cornify and actually get thickened. But I can't tell you how many cat paws we saw. Because cats are really difficult to catch when they're nervous and afraid. And then we have all the feral populations. So this is one of the biggest animals that we end up seeing. And then of course the dogs as well. We saw a lot of facial burns, mostly partial thickness, but we had a lot of full thickness on the ears, these poor little guys, and then some of the dogs with multiple injuries. So what do we do about them? So I had to show you guys a little bit of my tilapia stuff. So what's interesting about the burn care for animals, again, to think about is we are trying to learn from human medicine and encompassing different topical therapies, different multi-rational polypharmacy for pain, and then looking at what we can afford. And a lot of the biological bandages and temporary dressings we often can't afford in veterinary medicine. So we developed a biological bandage made of tilapia that is easily prepared, and we can take it out to on-site and start using it for these patients. So this particular dog actually had it on his nose and on his ears that were burned. And the most profound thing is, of course, the pain relief. And here's one of the cat. Not only does this cat have a wonderful face mask, but he's also getting acupuncture. So we do a lot of pain care for these guys. And then, of course, our little kitten mittens. So this was one of the ways we were easily able to try to do early excision of the eschar and then place the tilapia bandages on them. So just to finish off, again, to kind of sort of emphasize why it's important that we consider animals in these disaster planning. This is a patient of mine. His name is Chopper. He was owned by, or he still is owned by, a Marine who is stationed out in Japan. And Chopper was living with her father in Paradise. And unfortunately, he was at work, and Chopper was left in the house. So when the fire came through, it destroyed the house, and Chopper amazingly escaped. And the firefighters found him in the stream behind the house. And so when he presented to a local clinic, they were overwhelmed because we don't have that education. We haven't taught a lot of our veterinarians how to do this. And luckily enough, they called me and asked for help because this particular dog was all that they had left. And euthanasia was not an option at this point because they really needed him to try to survive. And in the past, I will tell you, these animals never went on. We did not allow them to be treated because it was thought to be unfair. But this owner said, I really need your help. So I went up there and I traveled up to Chico a couple times a week to treat his care. And we do a lot of this outpatient based. So once he stabilized, we were treating him outpatient because he can't afford to stay in the hospital. And all of his care was donated either by myself or by donors in the community. So as you can see, he had pretty extensive full thickness injuries throughout his back. And it's a little hard doing total body surface area in animals because our breeds are so different. And we were looking at least 40% burn. So then I turn him into an armadillo. But why this was important is this is when we looked at that particular dog, his pain control was one of the biggest things for me. And this allowed him to be able to go home and to have somewhat of a normal life and eat and come back for his bandage changes. And that's him today. So they can survive, they can go on to do well. And this is what's exciting about what we're doing, trying to develop the education, trying to make them a part of our disaster planning, because they are part of our family, part of our community, and do need to be considered.
Okay. Oh, okay. Well, we're working together, by the way, to develop the first veterinary burn center, which is going to be at UC Davis, but just saying. We're going to get there. It's going to take us a bit. We've already started in Alaska with a few things. We've learned a few things from these disasters. First thing is disasters can happen at any time. When the Camp Fire happened, we actually were down to burn surgeons, and I was actually supposed to give an EMS lecture on how to triage for disasters. Which, well, you know, didn't quite make that one. They don't happen always when it's convenient or 9 to 5. So you always have to be ready and have an idea of how to flex in your mind. You need to plan how to explain to other ICUs and other institutions. We actually sent two adults to Shriners. And the adults really loved it there. They did not want to come back here. I just don't understand why, but you know. Knowledgeable support staff is really the rate limiting factor. I can walk by and say, okay, you get 200 milliliters of IV fluids, 2 dressing times a day, 20 medications, and walk away. But someone has to do all that stuff. And someone who knows what they're doing has to do all that stuff. So that having that knowledgeable support staff is something to really think about and plan for. And we need service-specific line disaster declarations. Would you believe it? The Camp Fire occurred, and we did not declare a disaster here at UC Davis because we had hospital beds. We didn't have anyone who knew what to do with any of the burn stuff, but we had hospital beds. The fire service will get people out, but it's going to take a while. With one road in, one road out, you're going to get delayed presentation, which means harder resuscitations, more complications, longer length of stay. And communications become fragmented. There was only one cell tower that served the entire Paradise area, and that cell tower went down within minutes. Compounded when the Feather River Hospital closed, almost all communication about triage from that area stopped because the EMS providers were forced to just bring people down. And they did the best. They thank God for them and their protocols because they did the right thing. They brought people where they needed to go. Wildfires are also more than a one and done. We were actually triaging patients for weeks. Remember, this fire went from November 8th until it rained on November 22nd. Admissions are unpredictable. How do you triage for what may happen in 2 hours when the wind shifts and suddenly the population, a different population is at risk and may or may not get evacuated? Communication can be a problem. We talked about hospitals can burn down, and people are loyal to their houses and their pets. They will stay behind to save their houses, to save their pets at any result. And to confirm what Dr. Peyton was saying, the first things that my patients would tell me when they come in is my dog died in the fire or my dog got burned in the fire. It's still on people's mind. Treatment. The other thing that happened is people don't stop getting burned because there's a wildfire going on. Actually, people love to manufacture drugs at all times of the year. It's an equal opportunity thing. So we got patients on top of the wildfire patients with severe burns from other things. We talked about the difficult resuscitation because of delayed presentation, and the wounds from wildfire burns tend to be more deep because remember they're in a hot environment, and they also get the flame burn on top of it. So, you know, you're kind of baking in that heat and then an actual flame burn on top of it. Acute respiratory distress syndrome was very common, and the excisions required special attention. We talked about people being loyal to their houses, and I can't overemphasize, the animals really need to be planned for in disaster planning. And as I've spoken to the National Academy of Science and disaster planners, I'm emphasizing this point because you can't just say, well, we'll put the animals off to the side and we won't let them come in the shelters. The animals are part of the fabric of our families. And so we have to, because they're part of the family now, I think we have to readjust. It doesn't mean totally retool, but just think about how to accommodate without sacrificing hygiene standards, because that is the concern. Cats are a problem because, you know, they run away, and dogs, usually you can catch them back. And there's public health implications. And support was great. You know, the resources were good. The media was kind of split between us and the celebrity fire, which was actually kind of good because it left us alone a little bit. And there was lots of generosity. You know, did you ever hear them say, come on, send us clothes for the pile, and then about a week and a half later, please don't send us your used clothes, right? Because what they needed was clean underwear and non-used undergarments, but people were sending their old jeans and that kind of stuff. So generosity, as you can see, is both a good and bad thing. Sometimes lots of things pile up. Housing and sanitation can be a problem. The gentleman living with his chickens, I'm sure, was not meeting a lot of OSHA's sanitation issues. We all experienced the air quality problems. By the way, the N95 is probably the way to go, but it is problematic, and we sold out within the first day in the entire Sacramento area. And we talked about the animals. Wildfires are also expensive. Remember I told you the Tubbs fire was about $1.2 billion. The Paradise fire is $16.5 billion in losses. That is huge amounts. Burn patients will have a long hospitalization, and there's a real concern about the impact of air quality on long-term outcomes and loss of homes. There was a story on the news just the other day about the 76-year-old woman who went to live in Virginia with her family, came back to the house site and said, no way, and left. But there are people trying to rebuild their homes, and the toxins from the fire, because remember, houses are built out of toxic material when they burn, when it's combusted. There are some dangers there that everyone's not totally sure the extent of. And shelter use is variable, partly because of the animals and partly because of independence issues, and it's not disease-free. In terms of systems, we need to integrate the specialty consortiums. You know, what good is it for me as a burn surgeon to develop all these great rules for how to take care of patients if no one reads them? And the assumption in almost every disaster plan is that every surgeon knows how to take care of a burn patient for more than a couple hours. So the reality of a disaster is you're on your own for 72 hours if you're in the middle of a disaster. Don't expect any help before 72 hours. It takes that long to mobilize the resources. So think about, do you know how to handle a burn disaster for 3 days? And if it's that big a disaster, it's probably going to be longer. So think about that. We need to think about how hospitals evacuate and actually consider that in our disaster plans. It's not just how people evacuate to us, it's what happens if in the middle of an evacuation we need to evacuate. With wildfires, it's a real possibility. And the firefighters also had some gear things. So wildfires do require us some priority changes if we're going to address them optimally, because we have to think of how to benefit everybody in our society. And there are going to be more wildfires. We've had them already this year. We've been fortunate so far, not many other than people fighting the fire have been injured. There's going to be more guidelines. We're eventually going to get everybody together. Dr. Peyton and I are working on the human-animal interface, and she's changing the world with tilapia skin. And it's the teamwork that's going to get us through. The teamwork, forward thinking, and building. And we're going to learn how to do more with less. Thank you for your attention, and we'd welcome any questions. Yes, sir.
How did you get on the idea of using fish skin to cover these? I'm amazed it works.
Yeah, it actually, I'm even hesitant to say, but it works quite well. We've used it on 13 different species now and not seen any gross immune reactivity to it, which is exciting. But yeah, it's an interesting how, things come across. I always say patients find you, and you have to kind of find a solution. And the very first one I treated was a bear. So an adult bear presented with full thickness burns on all 4 feet. And the issue with wildlife is we can't go in there and touch them. They will kill you.
That's considered a bad thing.
but you also have to anesthetize them every time, and so that takes a toll on them. And because in the past, traditionally in veterinary medicine, we've used SSD, silver sulfadiazine, with just a bandage. And I thought, well, that's not going to work. And so I need some sort of biologic dressing that if they ate it, they wouldn't get a gastrointestinal obstruction either. So it's those factors. So I looked into what we had for xenografts, and I'll be honest, the majority I can't afford. Like, we just can't afford for that. And I thought, well, it's got to be something. And so I looked into other sourcing and started reading about fish. And specifically, tilapia has had more research on the collagen properties and the different components. And I thought, well, I think we could design our own protocol that would be easy and cost effective to use. And honestly, we didn't have much of other choice. And so I did it. And literally, it's my husband and I making it in the laboratory. And we started using it. And the amazing thing, again, is I had nothing else. And when we applied it, that very same day, she went from not being able to walk on her feet to waking up from anesthesia and walking. And to me, that's what the most profound thing is, that pain relief. And we didn't have to put a secondary dressing on that. And what's interesting, too, is that we found consistently with the animals, they've left it on their wounds. And that's huge, because animals, if it hurts, they will tear it off. They will continue to look at it. And so for them to leave it in place, to me, says a lot. So it's been a journey.
And Dr. Peyton got the Chancellor's Innovation Award for this, by the way. Yes, ma'am.
I remember reading after the shooting in Las Vegas and the evacuees to the University Medical Center down there, that they were in a situation where residents were called in and surgery residents were guiding family medicine residents over how to do pressure dressings and things like that. And what was really cool was that every single patient, 250 that made it to UMC, survived. Do we have any plan in place here for like a resident activation when you're saying like a doctor can be alone with these patients for 72 hours and figure it out? Like, we can, but I don't know of anything that's in place to mobilize us.
There is a hospital disaster plan, and that's reserved for, number one, the hospital has to call a disaster, which it never did for the Camp Fire. And if the hospital does call an internal disaster, that frees all of you up as potential to be doing just that. Yes, sir.
As you develop these disaster plans, are you getting support either from the state of California or the federal government? I'm curious, I mean, it's a bad political situation currently in that regard.
Yeah, with the current political situation, it's a bit challenging. But we're actually going the public health route, and I think that we're building up some impetus to being able to change some of these. The burn community has been working with the government for a long time on disaster planning, so we've been able to incorporate a lot of our concepts, for example, the triage diagram, into many of the disaster plans. Yes, sir.
It was a great talk. Really appreciate it. It'll be interesting to see the long-term effects of this, and I think you touched on it a bit, Dr. Palmieri, but just last month, Dr. Lisa Miller from the Primary Center at UC Davis gave a talk at the UC Davis Lung Day, talking about the lung effects of the smoke exposure that, I think it was the 2007 fire there, where the primates are all housed outside, and the primates that were born just at that time, they studied serially with CTs over 3 to 5 years, and their total lung capacity, their functional residual capacity, were dramatically reduced, and we get to see what the ramifications of this most recent fire will be.
Yeah, it's very interesting, and the burn literature shows that if you've had an inhalation injury, about a third of people develop progressive pulmonary insufficiency, a third develop a fixed pulmonary insufficiency that remains constant, and a third return to normal. So I suspect that their exposure was probably longer than the average house fire, and so they had that issue. Yeah, that's really cool, the primate experience. Yes, sir.
Thank you so much. In regards to the creation of burn centers, you mentioned some states not having any. Is that just hospital initiative, or is there state guidance given to that?
Right. Burn centers are essential components of taking care of burn patients. However, there's a few things that you have to have enough patients that get burned, okay, and some of those places are pretty sparsely populated. A second one is burn centers. We're an expensive resource. As I said, I have to kind of dodge when there's an administrative meeting about supplies. Okay, I'm kind of like missing. And the third is you have to have the personnel and be able to maintain their standards. So you have to have a certain number of cases to do that. And that feeds into it. And so for all those reasons, there are limited burn centers. Actually, a burn center just opened in Alaska this past year because they have frostbite issues and some burn issues as well. But it's a great question. Okay. Seeing no others, thank you very much.